Hello there, this is John, and this is the EMGM 106 Respiratory and Cardiac Arrest Review. So first, I know you learned the terms ventilation versus respiration. And so ventilation is the act of air moving in and out of the lungs, and respiration is the movement of gases across a membrane from the bloodstream. So consequently, you can break this down a little further. So ventilation it incorporates what's called the mechanical function of breathing. You have to have the chest rise and fall to move air in and out of your lungs. On the other hand, respiration is more metabolic. It's a body function. And this happens at a cellular level. So I'll give you a couple quick scenarios here. In the upper picture here, you have a 17-year-old female who's having an asthma attack. And as you've already learned about this, what's happening inside her lungs is she has bronchoconstriction. Bronchoconstriction is developing. She has a resistance in her lungs. She has a partial obstruction of her lungs, which is interfering with her ability to ventilate. Now, because of this, what's happening is her carbon dioxide levels are increasing. She can't breathe out her carbon dioxide as readily. Her oxygen levels are dropping. She's becoming hypoxic. Her chemoreceptors are recognizing this. They send out mediators, and one of the things they do is they start to incorporate accessory muscles. I'm sure you heard the term accessory muscle use. So now the muscles that she uses to breathe are working harder, and even her chest muscles, her shoulder muscles, she starts using extra muscles to try to overcome that increased resistance to her ventilations. The problem with all this is the muscles that she's using to try to stay alive are skeletal muscles. And these muscles are the same muscles as someone runs a marathon with, or someone who rides a bicycle 50 miles. And you can imagine that if an athlete's exercising and they get fatigued to the point where they can't go on any further, their muscles just get so tired, that's it, they're done. Same problem I have with this person. If we don't intercede, what's going to happen is she's going to become so hypoxic and so acidotic from the high levels of carbon dioxide. Her skeletal muscles, her intercostal muscles, her diaphragm, her neck muscles, her shoulder muscles, all those accessory muscles that she's using are going to stop contracting. And when her chest stops rising and falling, she's going to become so hypoxic that her heart is going to stop, and she's going to die from severe hypoxia. And of course, we want to intercede, high flow oxygen, maybe assist her with her inhaler if that's appropriate, and definitely get her to the closest, most appropriate facility where she can get treated and open up those bronchial tubes to resolve this problem. On the other side of this, this person down below, it's a 35-year-old male who was shot in the upper right quadrant of his abdomen. The bullet went through his liver, and as you know, the liver is highly vascular, and he's bleeding profusely into his abdominal cavity. Well, this person's problem is now a respiration problem, not a ventilation problem. His lungs are clear. He's got a great tidal volume. There's no airway obstruction. But because he's losing so much blood, his blood pressure is dropping, his perfusion is dropping, and not enough blood is getting back to the lungs to properly take away that oxygen and perfuse the body. So this person is also becoming acidotic because they can't off-gas the carbon dioxide, and they're becoming grossly hypoxic because they can't pick up oxygen. And again, if we don't intercede with high flow O2, rapid transport, shock treatment, going to a trauma center, this person's also going to die of severe hypoxia. So different mechanisms, different chief complaints, but if they're not treated correctly, the same end result. So I know that you guys learned about the various kinds of maneuvers to open someone's airway. It's pretty straightforward. What I have seen in the field, though, is there's some kind of weird disconnect with people. When you have a firefighter, paramedic, EMT, whoever it might be, and they open someone's airway, they automatically assume, and what I mean by opening the airway, I mean like tilt the head back or perform a jaw thrust. They automatically assume that the airway is patent. So just because the head is tilted back and the jaw has been, thrust forward, like you see in the pictures here, it doesn't mean that the airway's patent. And I've seen a number of times, I've gone on calls where you have an unresponsive person, someone's ventilating the patient, and even though they're squeezing the bag, no air is getting in, the chest is not rising and falling. And they're not even recognizing the fact that this is happening. They have this idea that if you squeeze the bag, the air is getting in. Well, it doesn't work that way. So when you're ventilating someone, make sure that chest is rising and falling. If it's not doing that, you've got a problem. You got to fix that problem, whatever it might be. It might be a suctioning issue. They could have an airway obstruction, maybe in the back of their throat. Maybe they got meat back there or something. Maybe you need to reposition the head, oral and nasopharyngeal airway, something, whatever it is. You've got about a minute to fix this problem. If you can't fix it yourself, call somebody over to help you to do this, because this is a priority situation. If you cannot ventilate a patient, they're going to die. Or if they're already dead, you can't ventilate them, they're not going to recover. So make this your highest priority. Now, I know you've learned to use the OPA. You know how to insert it, how to measure it, and all that. Pretty straightforward. What I do see out in the field a lot, unfortunately, is crews will go on fairly, serious calls. Because if you think about it, if someone needs you to place one of these OPAs, more than likely they're unconscious, maybe even in cardiac arrest. So it's a very high energy dynamic call. And so consequently, the crews will arrive on scene, they'll open up the airway bag, and they'll just grab the very first OPA they can find, and they'll just, drop it in. The problem is they haven't measured it. So there's a good chance that they picked the wrong size. So if they pick one that's too small for the patient's anatomy, what's going to happen is it's not going to grab the tongue and hold the tongue away from the back of the throat. The tongue's just going to fall back on the back of the throat, causing a partial airway obstruction. If they grab the one that's too long or too large, they're going to shove the tongue down the back of the throat, which is going to cause another airway obstruction. So this is when you really need to take that extra 10 or 15 seconds. Look at the patient, pull the OPA out of your airway bag that seems to be roughly about the right size. Do your measurement like you see here in this picture. If it's too small, too big, try a different one. Trust me, this 10 or 15 seconds that you take to do this is going to make your call run so much smoother in the end. Same thing with the nasopharyngeal airway. Properly measure, properly lubricate this device. Insert it carefully so you don't create some kind of nosebleed, which causes more complications. The big thing that I see out in the field with this particular maneuver is crews will try to use the saliva of the patient to lubricate the device. They're too lazy to go into the airway bag and pull out a packet of KY. The problem with the saliva, if you think about what's in someone's mouth, this person's unresponsive, they're in cardiac arrest, whatever it might be. Maybe they vomited, maybe they got food product in their mouth, maybe they've got stomach acids. I know they got bacteria and viruses and other kinds of things in there. And you lubricate this device with the saliva, shove it up their nose. It's not a very good lubricant, for one thing. And two, you're introducing all kinds of bacteria and stomach acid into their nasal passages and into their sinuses. You can cause an all really bad nasal infection or even a sinus infection from this. So don't do it. When it comes to ventilation, when to use positive pressure ventilation. If you have a patient who's semi-conscious or unconscious and they're not breathing at all, or their breathing is grossly ineffective, it's a slam dunk. You're going to ventilate with a BVM. The time when it gets kind of funky is the gray area. You have someone who's breathing at a normal rate, the chest is rising and falling, but you're not really sure whether it's effective or not. And this almost comes down to some kind of intuition, where you're looking at it, it doesn't feel right, it doesn't look right. Trust me, if you don't think it looks right, it's probably not. So don't be afraid to pull out the BVM on these patients and start ventilating them. As long as you do it correctly and safely, you can't really hurt them, and I guarantee more than likely your intuition is correct and they really did need it. So remember, make sure the mask is sized correctly. We have 6 different sizes of masks on our ambulance and fire trucks. So pick one that fits from the bridge of the nose to the cleft of the chin. Get a good CE grip, double or single CE grip. Make sure you're using the right size BVM. Make sure there's some kind of appropriate adjunct in place, nasal or oral pharyngeal airways, and ventilate at the appropriate rate and depth. You can't really hurt this person if you do it correctly. So just don't be afraid to pull the BVM out if you think you need it. Now, as of this year, the County of San Diego now requires all patients who are being ventilated with a BVM, we're supposed to use a PEEP valve. So that's that red little cap that's on the end of the BVM in the picture right there. It's got a spring in it, it's got a little valve in it, and you can adjust the pressure, or should I say the paramedics can adjust the pressure for this. And what this does is when you ventilate someone with a bag valve mask, air goes into their lungs, but only a part of it comes out. So the PEEP valve retains some of the pressure in their lungs to keep the lungs open and keep the alveoli open to allow a better exchange of gases. Now, there's a couple contraindications. Because this increases the interthoracic pressure of the person, it can drop their blood pressure. So one of the contraindications is any blood pressure less than 90 systolic before you can use this. Also, if you're suspecting a possible pneumothorax, so they could have a ruptured lung, they could have a hole in their lung for some reason, this extra pressure would only make that worse, so that's another contraindication. When it comes to EMTs using these, if you're working with a paramedic, you're going to install this PEEP valve on the end of your exhalation port of your BVM. It's already preset at the lowest pressure setting, and EMTs can use these. They can install them. They can ventilate patients with them. The one thing they cannot do is adjust the PEEP pressure. If you're working with a medic, the medic can adjust the pressure. You can still keep using it as an EMT, but you just can't physically change the pressure yourself. So these are pig lungs. I'm sure the Piggy Wiggy's in the barbecue somewhere. And what's going to happen here is this gentleman is going to ventilate. And what I want you to look for is the fact that right now there's no PEEP valve on this system. And you'll notice that when he does ventilate, there's obvious rise and fall of the chest or the lungs, I guess, no chest here. And what you'll notice is pretty much all the air leaves the lungs. Once he attaches the PEEP valve, you'll notice that things change. Let me show you. So notice how they're rising and falling. Pretty much all of the air is getting exhaled from the lungs. So now he's going to attach the PEEP valve to the exhalation port. And you'll notice now there's actually pressure being retained. And the idea behind this is it opens up the alveoli. This is really good for drowning patients, people with pulmonary edema, CHF patients, asthmatics. It really helps the exchange of oxygen and carbon dioxide, improves it drastically. And you can see again, without the PEEP valve, this complete collapse of the lungs. Okay, let's move on to cardiac arrest management. Okay, so I know you guys have had your CPR class and you learned the skills, and even though those basic skills are really important, they're just a small portion of what goes on a CPR. First and foremost, it's really, really important that we have a strong team leader. That could be you, if you and your partner show up and start doing compressions and ventilations. It's important because these scenes can be really dynamic. They can be really distracting. And if there's not someone there to keep the team focused, it just won't run quite as smoothly as it should. So as the team leader assigns different roles to different team members, they're also going to ensure that those skills that they're performing are done correctly. The correct depth of compression and the ratios and all that. They're also thinking ahead. They're thinking, okay, so we started CPR, we're doing this stuff. What am I going to need in 10 minutes to move this person to the hospital, or maybe not? Also, on top of all that, there might be survivors there as well. So you have family, friends, coworkers there. The team leader, if there's enough resources at scene, they're going to assign a person to interact with these survivors, keep them informed, ask them questions about the patient, their name and their age and their medical history and all that. They're also going to assess the survivors as well to make sure they themselves aren't becoming patients. There's been calls that have gone on where one of the family members, one of the coworkers, had become so overwhelmed by grief due to what's happened that they themselves wind up getting transported to the hospital because they're in such distress. Also, the team leader and, of course, whoever's been assigned to the survivors can think about what kind of support these people might need to help with closure to whatever's going on. On top of all this, the team leader is going to be interacting with the crew, the team, and they're going to be getting feedback from how this patient's responding to the care. There's going to be a decision made about, are we going to transport, are we not going to transport? If we are going to transport, what destination are we going to go to? Is it a trauma center? Is it a medical center? What resources do we need to move this person from where they are to the hospital? Gurneys and additional hands and, of course, an ambulance. And then at some point, contacting the base hospital, have to assign someone to do that. If it's determined that this patient is not going to be transported, then you're thinking about police officers, sheriffs to take over care of the body and for them to call the coroner's office. Now, common reasons why people go into cardiac arrest. Most commonly, it's going to be an electrical problem. This is a case where the electrical conduction of the heart is interrupted primarily due to hypoxia, and because of this disruption, the heart starts to misfire. It goes out of sync and can no longer pump blood or stops pumping blood completely. So the heart structure itself is intact to some degree. The electrical conduction is somewhat intact. There's no real permanent damage to most of the heart anyway. And so this is a medical patient. On the other side of this is you have mechanical problems. This is a person who's been stabbed in the chest or shot, penetrating trauma, blunt force trauma, falling from 30 feet to the ground, being hit by a car at a high rate of speed. And what they've died from is massive organ damage and subsequently blood loss. So somewhere in their torso, whether it's the liver, spleen, aorta, lungs, heart, whatever it might be, there's major damage in there. Organs are torn up. There's massive blood loss. The blood is pumping out into their abdominal cavity, their thoracic cavity, and there's no more blood left in their bloodstream. So even though the heart itself might not be damaged, potentially, and it's still trying to pump, but because there's no fluid, the pump can't pump and there's no pulse. So this person has a traumatic injury and that's what they died from. They have very, very low chance of survival. Now, how we treat these patients really depends upon a number of things. So the causes do play a major role. And from a very simple perspective, if this is a traumatic arrest, they died from massive trauma, their best chance of survival is rapid transport off scene to the closest, most available trauma center. So we're going to start CPR, get them on a spine board, and transport. On the other side of this, if this is a medical patient who's died from a medical cause, like drowning, or like electrocution, or even a heart attack, their best chance of survival is here and now because their organs are somewhat intact. Their heart might still be viable, and if it is, they'll respond pretty quickly within that 5 or 10 minutes of they're at scene. Presentation also plays a big role as well. So how long have they been without a pulse? This is called downtime. The longer you're without a pulse and no one's doing CPR, the less chance you have of survival. So it's good to know downtime. If they've been down for 10, 12, 15 minutes prior to arrival, their chance of surviving is very, very, very low. And even if they do, they're probably not going to walk out of the hospital, and they're probably going to have permanent neurologic damage as well. Location plays a big role as well. If you're in a private residence, of course, it's pretty straightforward. It's a very stable environment. There's not a lot of bystanders and other people around, hopefully anyway. And so if this is a medical arrest, we're going to stay and play. And we're going to do that right there on the kitchen floor or the bathroom floor, wherever we might find the person. If you're in a public area, like a place of business, like Walmart or a restaurant, someone dies of a medical problem in a restaurant or other place of business, the business owner, the manager, really doesn't want you there. They won't tell you this outright, but you can tell they're not comfortable with us there doing CPR on aisle 3 of Walmart on Christmas Eve. It basically disrupts their commerce, and they really don't want us there. So we try to accommodate this. This is a medical arrest. We'll probably start CPR. We'll probably do 1 or 2 rounds of compressions. We'll attach the AED. We'll load the person onto a spine board, and then we'll get them out of this place of business into the back of the ambulance. It actually works better for us anyway, because we're out of public view. It's a much more stable environment for us. It's safer for us anyway. And it's really kind of a customer service thing when it comes to dealing with these business owners. If you're in public view, like at a venue like Petco Park, or you're downtown on the sidewalk somewhere, or you're at the trolley station, maybe even on the trolley sometimes. Those are kind of dynamic situations. And even though you have a medical arrest, like someone died of a heart attack, you're probably going to want to move them a little more quickly as well, because you want to get them out of public view. You want to get them out of situations where there might be crowds. Those crowds might be hostile. They might be intoxicated. You probably don't want to be there too long for safety reasons, so you want to move them more quickly. When it comes to law enforcement, you can and will probably get called out to law enforcement involvement where there was some type of arrest process or shootout, and the assailant was shot and killed by police or sheriffs, and they're going to call you to scene for an evaluation of the patient. The problem with all this is, for us, is this is a crime scene, and the police or sheriffs, they have their own internal protocols about the integrity of crime scenes, and they might not let you in to evaluate the patient for 5 or 10 minutes. So don't be frustrated by this. Just realize they have to follow their protocols, and they're actually legally in charge of the patient's care because this person is in custody. So wait until they wave you in, and then do what you got to do. You learned about withholding CPR. You learned about DNRs already, and pulse, and the fact that they're valid and they're present and all that. So it's mostly pretty straightforward, with some exceptions, which hopefully your instructors talked about. Obvious signs of death, again, pretty straightforward. You do not have to start CPR. Now, if you work as an EMT in the County of San Diego, at some point in your career, you're going to interact with paramedics. Either you're going to be working with one on a fire truck or an ambulance, or you're going to arrive at scene where they're either there already, or you're going to call them to scene. What's really good about this is the County of San Diego has this thing called TOR. And this protocol, it stands for Termination of Resuscitation. And this is only for paramedics. And the medic can come to scene, and by evaluating the patient, they can pronounce the patient on standing order. They don't have to call base hospital to get permission. If it's a medical patient in asystole, which basically means flatline, they can just say no more CPR, they're done. Same thing with the traumatic arrest. If they've died of some type of blunt or penetrating trauma, and they're in asystole, the medics can pronounce on standing order. So it's really great because many of these patients don't really need to be transported. And it's actually, if you do transport this person unnecessarily, it can lead to big bills to their family, medical bills for their family. and it's an unnecessary use of resource of the EMS system. So the County of San Diego adopted the 10-to-1 compression to ventilation ratio about 12 or 13 years ago, and it works just really, really well. So we no longer use 30-and-2 for adult patients. And so the compressor is doing around 100 to 120 compressions per minute. Every 10th compression, the ventilator squeezes the bag, and this gives the person in cardiac arrest, more continuous compressions, less time off the chest, and it still gives them about 10 or 12 breaths per minute as well. It works really, really well. If the patient has any kind of viability about them, it will help them to hopefully achieve, ROS. When paramedics show up, or if you're working with a paramedic and they insert an advanced airway, then things change. Because the advanced airway is much more effective at ventilations, there's no longer a ratio when it comes to compressions and ventilations. Now the compressor compresses the chest, 100 to 120 per minute. The ventilator is ventilating 1 every 6 seconds, and there's no coordination. The compressions are continuous, and they're asynchronous to their ventilations. Again, once this advanced airway is in place. Same thing with pediatrics. It's the same rate, 100 to 120 per minute. Even though the county does say that if you want, you can use American Heart's standard of 15-and-2 on these pediatrics. Pretty much every agency that I know of in the county uses 10-to-1, even on kids. And again, with the advanced airway in place, if you're working with medics, you can also have the continuous and asynchronous compressions as well. The one variable to this is the neonates, the newborns. That ratio still remains 3-to-1, and that's American Heart standard. And I think we're done.